site. Today is all about oncology, and to talk to us about that, we have Dr. Ricky Frazer, who's a medical oncology consultant working at Valindra Cancer Centre in Cardiff. He specializes in renal cancer, skin cancer, and acute oncology, and is the clinical lead for the Acute Oncology Assessment Unit at Valindra and the Immunotherapy Toxicity Management Service. He's one of the founding members of the UK Renal Oncology Collaborative, and he recently completed and was awarded a distinction in the postgraduate certificate in acute medicine at the University of South Wales. He was a Welsh Clinical Leadership Training Fellow with the Wales Deanery and is founding Associate Fellow of the Faculty of Medical Leadership and Management. He has a strong educational interest and is currently a Royal College of Physicians College Tutor and Faculty Lead, and also an honorary lecturer at Cardiff University. He's been heavily involved in the inception and development of the National Practical Management of Your Immuno-Oncology Patient educational series, exploring immunotherapy identification and management with specialist colleagues. He's co-founder of a podcast also called The Immuno Buddies, launched in 2023, which covers the use and management of immunotherapy in treating cancer. And it's freely available on a number of online platforms, including Spotify. So thank you so much for joining us today.
Great to be here, and apologies that the bio is so boring and long, but you did a great job with it.
So can you begin by telling us a bit about what a typical day or even week is like for you?
Yeah, no, great question, and delighted to be here. I think it's quite varied so I'm a medical oncologist, is the first thing to say. And so oncology as a specialty is really divided up into medical and clinical oncology. So, and we may talk about this later, but a medical oncologist doesn't deliver radiotherapy, and so that will be worth us exploring. So I'm very lucky. Probably from the bio, you see that I'm a bit of a jack of all trades and a master of none. And so I do some outpatient work, I do some inpatient reviews, I do some time on the assessment unit seeing patients with cancer who've got acute complications or other issues with their cancer. And then I do the immunotherapy toxicity service stuff and lead that. So it's quite varied. Some of it will be in outpatients doing clinics. Some of it will be doing ward reviews. Some of it will be doing supporting education, giving lectures, and some work with the Cardiff University doing that sort of stuff. So it's quite varied, a mixture of inpatient, outpatient, and non-clinical activities.
Perfect. And can you decipher or distinguish between the medical and clinical oncology for us a bit more?
Yeah. So if you ask my clinical oncology colleagues, they would say that I get paid just as much and do half the work, which is absolutely fine by me, by the way. So I think that the main distinction is around radiotherapy. So a clinical oncologist would deliver what we call systemic anti-cancer therapy, or SACT, which is not just chemo nowadays, but would be immunotherapy, targeted therapies, hormone therapies, and increasingly as we move forward, it will be gene therapies and advanced cellular therapies. And again, we may or may not get into that. But a clinical oncologist would do some of that, but often not quite as much of that. But we'll do radiotherapy treatments. So we'll either do palliative radiotherapy treatments where we're aiming to control the disease, or also radical chemotherapy treatments where they may be treating the cancer with the aim of curing it, either with radiotherapy alone or with radiotherapy alongside maybe one of those systemic anti-cancer therapies.
Perfect. And we can get into why you chose your distinction a bit later, but can you tell us a bit more about some common presentations that you may see?
Yeah, so I guess it would depend on which part of my practice we're looking at. So in terms of presentations, if it's my outpatient practice where I primarily see kidney cancer patients and skin cancer patients, well, those patients will often, my kidney cancer patients may present with abdominal pain and hematuria, and then have a CT scan and be found to have a kidney tumor that gets biopsied, and they may have spots in other parts of the body, so metastases elsewhere. And so they would then get referred to me for me to see them for systemic therapy. Similarly, with melanoma, that might be another story. They've got a skin lesion. We do a scan. They've got mets in other places. or they may have had that tumor removed and they send them to me to consider an adjuvant therapy to reduce the risk of it coming back. So that would be my outpatient work. And then my inpatient work would be seeing patients who've got complications of their cancer or complications of a treatment of cancer, and managing their acute presentation. And then the IO toxicity world will be someone who's on immunotherapy, which again we may or may not talk about, which is a fairly new type of treatment, and I'll be managing, their array of potentially of toxicities.
Perfect. And do you spend most of your time doing inpatient or outpatient work?
Yeah, that's a great question. So most of my colleagues will primarily be outpatient based. So most oncologists, it's primarily an outpatient based specialty. I've got a fairly wide portfolio, I guess, in terms of what I do day to day. So I have a fairly even mix between inpatient, acute oncology work, and my outpatient work.
Okay. And how do you find that? Do you prefer inpatient, outpatient, or do you like the mix?
Yeah, no, I love the mix. So I think one of the great things about doing oncology is that variation in what I do. So, I do some teaching, I'll do a little bit of leadership, I'll do a little bit of acute assessment, and then I'll have my cohort of patients that I know incredibly well that I meet on day one, and I will look after them either till I can cure them or until they die. And that's an immense privilege to have that real genuine paternalistic relationship, which I think in medicine nowadays it's almost frowned upon because we spend so much time talking about co-creation of plans and empowering patients, which by the way is all fantastically important. But actually being able to develop those relationships with that patient, that patient inside out, everything that matters to them, every important event in their life that will be coming up, and you tailor a treatment plan that's absolutely geared around their priorities.
And would you say that the variation is one of your favorite parts about the specialty, or is there something that tops that?
So I think the variation is one of the things that I enjoy most. I think one of the thing that I enjoy more than anything is that real connection that you have with patients. So I do a lot of interviewing for medical school, and at interviews I hear lots of people saying things like, "I want to do medicine because I really like science and I really like patients and I'm really empathetic," and I hear that, and it's great because that's exactly the right qualities. But if you do genuinely like science and you do genuinely like empathy and having those relationships with patients, I mean, there isn't really another job that gives you all of that in the way that oncology does, because it's changing every day. Every day there's research which changes the abilities to keep people alive. But that relationship that maybe people had with their GP in years gone by, where they knew everybody, they knew all the family, is really hard nowadays, I think, in primary care, because it's so fast paced and there's so many patients. But I know that about nearly all of my patients. And I get to develop those really deep, meaningful relationships, which means it's difficult when I break bad news, but it means it's, even when I'm breaking bad news, it's a real privilege to know people to that degree, to that level. And that's, I think, the thing I love most about the specialty.
And would you say that being able to connect with patients in that manner is a personality trait that you would look for in an oncologist?
Yeah, I think it definitely is. And I think, that's one of if you're going to be, if oncology is going to be your passion, you need to be somebody that likes what I call the softer side of medicine. So the holding patients' hands, the getting to know them, you know, getting to understand what's important to them. And in a way I become their GP, because they, if they're on treatment and they're seeing me every 2 or 3 weeks, inevitably there are things that will come up, like, their sugars may become a little bit more difficult to manage, or their blood pressure is a little bit tricky. And so you also get to be a real general person in the way that you manage lots of those things. And again, that's a real privilege, and a pressure, but a pressure that I love having.
Mm. And on the flip side, what is your least favorite part about the specialty, if anything?
Okay, that's a great question. What's the least enjoyable part? I think I think probably I think probably it's when you have a difficult day, it's difficult. So when I have a clinic where I've got, maybe I'm seeing 12 patients and 11 of those are bad scans, that's really tough. That's and each patient deserves the fresh Ricky to go and see them and be empathetic and feel that empathy with them. But when you're on patient 9 or 10 and you all you feel like you've done is break bad news and destroy, you know, people's lives, and I don't mean that in a you're trying to destroy it, but when you're breaking bad news, when you're stopping treatment, that's for them, that's the biggest thing that will ever happen to them. So when you've done that a number of times in one clinic, that's tough, and you need to be prepared for that emotionally.
Mm. One of the guests I had on the podcast, Dr. Kyle, he said he was really interested when an episode about oncology came up because he wanted to hear how oncologists tackle bad news and how they tackle the emotions related to that. So, how would you respond?
Yeah, that's a really good question. The way I try and approach those things, and I often say this to my patients, is, you know, I'm going to do for you what I would do if you were a relative of mine. And so, and I think that's always served me really well as a doctor. It served me well as a doctor before I became an oncologist. But I think all we really want, so if tomorrow one of my loved ones gets cancer and goes to meet their cancer team, if I thought they were doing for my relative what they would do for their own relative, I'm pretty certain that's the bar that would make me feel like that's enough. That's what I want. And so I always try and see every patient and say, if this was my relative in front of me today, what would I do? What would I want to do for them? And I think that's always helped me as a doctor, but it's also helped me just be able to know that I'm doing what I think is the right thing, because we don't always make the right call. But if you always know you're doing it with the right view, or what I think is the right view, that allows me, I think, to go home and know that I've emotionally invested and I've done everything I can do.
Mm. And I think that that's a great point that if you relate it to how you would treat a relative, it becomes more personal almost, which can be difficult emotionally, but at least you know that you're giving them the best care that you possibly can. When we held our careers fair for MedSoc, a lot of people were asking the oncologists who came the same question, which was how they dealt with this bad news. And I think there's a stigma that if someone is diagnosed with cancer, it's almost like you're telling them this is the end. But with all of the advances, that's not really the case. So how do you change everyone's mindset about that?
Yeah, it's a battle. So, um, I've still got, so I treat melanoma, and melanoma a few years ago was, if you had metastatic melanoma with lung metastases and liver metastases, we only had one type of chemo. It wasn't particularly effective, and nearly everyone died within 1 year. And now we've got immunotherapy drugs, which again, I can talk all day about, but I'll try not to work by stimulating the patient's own body's immune system, and that's what I talk about on the Immunobuddies podcast is around immunotherapy. In melanoma now at 7.5 years, almost 50% of those patients are still alive, and that's with stage 4 metastatic cancer. Many of those patients will no longer be on treatment. Many of those patients will be in complete remissions. And so that's a paradigm shift. We're talking about stage 4 metastatic disease, the sort of patient, if you're on placement, you assume is going to die quickly. And I'm talking about potentially curing them. And so we just have to talk about those messages and make people aware that that's where we are now. And other tumors are catching up as well. So, where I want to get us to is that cancer is a chronic illness in the same way diabetes is a chronic illness.
So it's just about getting the message out, and hopefully with time, people begin to understand, especially medical students who may be afraid to go into oncology, that, we are coming up with new therapies, there are new advances. And I can tell that you're really excited about immunotherapy. So do you mind talking about that a little bit?
Yeah, no, very happy to. I guess just one more thing to say before I talk about immunotherapy is
Yeah.
that fear of people dying and that being a cancer specialist will involve managing people dying. I actually think that's probably the most valuable thing you can do for any patient. So I won't share it on this podcast, but one of my patients passed away a couple of weeks ago, and her daughter WhatsApped me the other day just to basically say that, you know, the hope that I was able to give them, and the compassion at the end of her life, and helping her die well in the way that she wanted to die, was more important to them than anything else I did in that journey. And so I whilst it's difficult for people to die, helping people die well is so powerful. And so if you can do that well, if you've got that inherent care about people and patients, and I work very closely with my palliative care colleagues, and I think I could have easily done palliative care. I think those kind of things that we maybe see as negatives, oh, the patient died. Actually, if you can help someone die well, is just incredibly powerful. Um, but to talk about immunotherapy, which is, I guess, the flip side of that. So immunotherapy has revolutionized cancer. So we're using immunotherapy. I think it's now 15 or 16 different tumor types we've now got immunotherapy in. And it's basically, and all that medical school stuff you learn that you think you get to forget, it turns out you can't. Because actually what immunotherapy is using drugs to basically stimulate CD8 T cells to be able to attack cancer cells. And it's basically removing checkpoints, which are inhibitory pathways that stop those T cells and allow those T cells to be more effective at recognizing epitopes and antigens on the tumor cell and attack them more effectively, and kill them more effectively. And harvesting, you know, CD4 helper T cells, and working with other immune cells like macrophages and dendritic cells. And so the really great thing about immunotherapy is we are getting to the point where we can get the patient's own body's immune system to fight the cancer. And patients hate the idea of having chemotherapy. They hate the idea, most patients, of using the body will kill cancer cells, but also kill their own cells. But they love the idea of stimulating their own body's immune system to kill the cancer. And so it's just changing the landscape completely.
Yeah, it sounds like there's so much to learn. And I remember when you did one of our lectures on it, and I was completely mind blown, because immunology, firstly, is not my strong point, but also is so fascinating to think that these advances do exist and what's going to come in the future. And for medical students who want to learn a bit more about immunotherapy or just the specialty in general, do you have any resources that you can recommend?
Yeah, no, so there's always, so the first thing to do is I say wherever you are training, reach out to the oncology team. So most oncology teams are delighted to have medical students who've got an interest, and so many of us do SSC projects, and I know that will have different names in different medical schools, but in essence, we're, you know, student selected opportunities. So those things exist. You know, in terms of things that I can recommend, so, you know, the ImmunoBuddies podcast is freely available. And in fact, we've just done 2 episodes where I had 2 medical students from Cardiff come on and in essence interrogate me and my colleague for an hour, asking me and us all manner of questions that medical students would want to know. And so again, just put the ImmunoBuddies into Google and they're freely available. We don't make any money from them. In fact, I pay £30 a month just to I co-chair a national meeting once a month, which is essentially an immunotherapy meeting, but we talk about all sorts of things related to cancer and immunotherapy. It's on Microsoft Teams. It's always the first Thursday of every month at 1 o'clock. And so again, you could join the distribution list, which I manage, and you could join, you know, once a year, every month, once every 5 years. It's just there, and you'll get the agenda each month. And if you like the topics, great. Again, anyone who wants to join that can email my personal email address. So it's ricky.frazer, which is ricky.frazer, FRAZER at wales.nhs.uk. And I'm always very happy to try and link people into those kind of things.
I'll put your email address in the description as well for anyone who wants to get into contact. And now we move into the part of the podcast where we talk about how you arrived at being an oncologist. So, why did you choose the specialty?
So I think oncology almost chooses you.
Mm,
So I think through medical school, I was always somebody who liked the softer side of medicine, the bit the kind of soft skills. I enjoyed the deep relationships you get to have with patients. And then I did my junior doctor years, and I really enjoyed. I was very lucky, so I've always enjoyed all the jobs I've ever done. I always finish each block and go, oh, I could be a gastroenterologist, I could be an endocrinologist. And then I did care of the elderly, and I thought that feels like a good fit. That's very holistic, and it's about optimizing the patient. So that felt like a good fit. And then I did a year in Australia, and I went out and worked there, and I really enjoyed that. But then within my sort of core training years, I did an oncology job at Velindre Cancer Centre, and for me, it ticked every box. So I liked research, I liked new developments, I like new things, I get excited by that. So that ticked that box. But it gave me the sort of general medicine, acute medicine stuff, which the managing complications and challenges of, around unwell patients. But the bit about oncology for me was that real synergy between palliative care, between giving hope to patients, making difficult decisions. I enjoy challenging cases. I enjoy difficult decisions. And then the other things that maybe are arguably equally important nowadays is it's a good work-life balance. So it's not the general medical reg life, which I think is still probably the hardest training scheme there is. That's my opinion. Most of my on calls were from home, even as registrars, and all of them now are from home as a consultant. And so those things are really important. The training scheme was just between Cardiff and Swansea. So again, I wasn't being sent all around the UK for placements during my registrar training. And so it was really just a great balance between an academic interest, a real personal patient care, and a good quality of life.
So it sounds like, yes, it was a great fit for you. And what is the training pathway like?
So that's changed a bit with the sort of the IMT training. That's the sort of newer training scheme. But in essence, keeping it simple, is you would finish medical school, you would do your foundation doctor years, and then you would go on to IMT training, so internal medicine training. And what you would typically do is either 2 or 3 years of internal medicine training, and you can then apply to either do medical oncology or clinical oncology. And then, depending on which one, so medical oncology is 4 years of training, clinical oncology is 5 years, but many people will take time out in their training to do research or leadership or education.
Okay. And would you say that it's quite an intense program? I know you talked about being able to do your registrar training, some of it from home and things like that, but other than that,
Yeah, I don't think it's particularly intense. There's a lot to learn. There's a lot of new treatments to learn. There's lots of tumor types to learn. But I think it's I think probably just about right. I think there's enough in there that it's, you're not thinking, oh, we're redoing stuff, I'm ready. But I think that the time frame is about right. I think it's a little bit different as a clinical oncologist because you've got to learn all the radiotherapy, and there's quite a lot of physics, and which I struggled with, which is why it was never going to be the way I went. But so it's a little bit, there's a bit more physics, there's a bit more biochemistry in some of the clinical oncology training, and a little bit of maths again in terms of alongside the physics. So that's probably a little bit harder, and I can say that as a medical oncologist. I think clinical oncology training is a bit harder, but I think both specialties are a great career. So I'm 5 years into being a consultant, and I absolutely still love every single day. I'd never wake up, I never think I've got to go to work today. I absolutely love what I do.
I can tell your passion by just talking to you as well, which is great because previous guests always talk about do something that you're passionate about, which is true, because at the end of the day, you have to do it for years upon years upon years. Can you think about any personal or even professional sacrifices that we have to consider when choosing any specialty, really?
I think the biggest sacrifice is you invest your heart and soul into your job, and and I think medicine is still a vocation in that sense. But I think you do sacrifice things along the way. So I've been doing exams pretty much my whole life, and I still have to keep up to date. I'm still, on weekends I'll still be looking at new treatments coming through, and I'm looking at the early data, and I'm thinking about how I can get my patients onto trials. And so I think particularly with oncology, it will never end. So you'll never know everything. Every day is going to be a school day. So if you want to get to the point where you feel like you know everything, oncology won't be the way to do that. If you want to get up every day going, this is gonna be different. So the sacrifice is that you'll always have to keep learning, and patients, that time in their life where they get cancer, which is probably going to be their hardest journey, they will look to you and they will say things like, my life is in your hands. In fact, I've had that said to me 3 times this week. I will do whatever you want me to do. My life is in your hands. And so a sacrifice is knowing that responsibility and taking that responsibility seriously, which is an incredible privilege, but it's one we shouldn't take lightly.
It does sound like a very heavy statement to be said to you. How did you feel, if you don't mind me asking, when they told you that?
Yeah. So I don't know. I love that. So I love that pressure, because as long as I wake up every day and do my best job, I can live with knowing that I've done the best service I can do for that patient. So I love that. I love the fact that they feel that they can invest that much in me as a person, as a clinician, because I don't think you can differentiate those two people. I think ultimately people know what authenticity looks like, and they'll see that or they won't see that. So I really like that pressure. But I know some of my colleagues who just would say, that's not, I don't want to feel that level of pressure. I don't want to feel that level of responsibility. In which case, there are other careers out there that are probably better suited. But for the right person who likes to be at the center of difficult decisions and really satisfying developments and powerful journeys, it's I think it's the best career by a fair stretch.
I really admire how you find these statements and these pressures and challenges positive, because it shows a different perspective almost. Some people may be afraid of it or even shy away from it, but you just run head on into it. And I think, again, that's testament to your passion and how much you love it. You've given us a bit of a few golden nuggets throughout the episode, but now we come on to the advice portion of it. And my first question is, if you were speaking to a medical student or a junior doctor who's a bit overwhelmed, they're not sure what specialty they want to pursue, but they have to start thinking about it, what advice would you give them?
So my initial advice would be, ask lots of questions. So there's I love people who say, can I come and spend a day with you, or can I come and spend a few days, or I think sometimes as a medical student, because although I'm now old and a consultant, it feels like yesterday I was a medical student, in Cardiff doing my first placement. And I know that feeling. I still try and always remember how I felt when I felt, that I was just in the way and I'm just wandering around, and it felt a bit aimless sometimes. But now being on the other side of things, actually, I would have, what I should have done as a medical student is said, can I have a few minutes at the end of the ward round and just chat through your specialty, or chat through what's important to you, or anything, we've had that interesting case today. Have you got a couple of minutes? In reality, 95% of doctors would love to spend a few minutes and just talk through what was interesting, what was challenging, what can be learned from it. So I think ask lots of questions, and don't be scared to say, actually, I don't know what the right thing to do is. So I'm doing this now, and I love being a medical oncologist. I still love acute medicine. I think I would have been very happy being an acute medic. And so I think it's also looking at what specialties are out there and seeing what you can do within that specialty. So I'm a medical oncologist, but I do oncology, but I also teach, I also do some leadership, I do some immunotherapy, I do some inpatient work. And so more and more, it's promoted to have portfolio careers. And so it's worth looking at the specialty and actually looking at what could I do within that specialty that's different, or an extension of what people are already doing. I think the idea that you're going to be a medical oncologist or a rheumatologist or a dermatologist, and that's all you're going to do forever and ever more, that's not the world we now live in. And so I think, be innovative. So if you think, actually, I love geriatrics and I also love oncology, well, actually now there's oncogeriatrics, which is a specialty in itself. And so it's just about seeing, how you could carve a role that's going to keep you really interested.
It sounds so simple to just ask questions, but for some reason we don't do it enough, and I don't know why.
Yeah.
Okay, so thinking back, you have been a consultant for 5 years, you said, and it's been a long journey to that point. So can you think of anything that you'd have done differently?
It's a great question. I think, what would I have done differently? I probably would have stayed in Australia longer. Um, so, which isn't never great to say on a podcast. And I think, I think I never did a job that I thought I didn't get value out of. So I think, don't be in a rush. There's training schemes and they're there for a reason. But if there's something you're interested in, taking time out and doing a fellow role or going to spend a few months doing some locums is absolutely fine. You're going to be a consultant for a long time. And so, what would I do differently? The things I would do again, and maybe if I was going to do it differently, I'd do them for longer, is I took a year out and did just leadership training for a year, which was fantastic. At the time, people thought I was crazy, but I was able to spend some time in MIT in Boston. I was able to interact with people in Welsh government and build links. So I think what I would do differently is I would do more of those experiences, because they really enrich things. And I guess the other thing that I think I've been fortunate enough to do is I was an inpatient. So during my training back in 2017, I developed Guillain-Barré syndrome and was in hospital for almost 6 months, and then had to learn to walk and talk and all those things all over again. And actually, I learned so much from being on the other side of the fence. So that's not saying that I want everyone to be a patient. What it does mean is talk to patients about what's important to them, because it's really easy as you go through your training to forget the vulnerability that comes with being a patient. And I certainly know, and again, for anyone who's interested, I wrote a paper in BMJ called Doctor Through the Patient Lens. And there were things that I had forgotten. So I was right next to being a consultant. And there were things that I had kind of forgotten during my training that all of a sudden, when you're a patient, become really important again. So don't listen to what's important to patients, because if you use that as a guide for you, you won't go far wrong.
So that experience, which at the time may not have felt very great, was actually something that you took away, and now you can transfer those skills and those memories to how you treat your patients, which is great, because you would take care of how other clinicians may approach the situation. And you also spoke about taking time out to explore different interests. And some people think that taking time out may be a detriment to progression in training. What would you say to that?
Yeah, I would say it's simply not. So
Mm,
I think the people who may view it that way are probably the people that you don't want to be working alongside for the rest of your careers anyway. The people I find most inspiring are the people who've gone and made their own journeys, who've taken risks, who've risks in their profession, in the sense of looked at opportunities, said, actually, I'm going to try this and see if this is the right thing for me. Because all of those things, all those experiences ultimately round you as a human being, round you as a doctor. And so I would say people who are saying you shouldn't do that, you should just decide what you're going to do and keep your head down, are probably not the people that you want to be spending your time with anyway. The people that have got portfolio careers, who are doing lots of different things, are the people that I gravitate to. They're the people who I go, actually, that's somebody I want to spend time with, both professionally and personally. And so I think, be true to yourself. So there'll be lots of advice that you get along the way, but always reflect back and say, actually, what's the thing that gets me out of bed every day? What's the thing that I value most? And for some people that will be pure science. For some people that will be patient care. For some people that will be, actually, I don't want direct patient care and I want to do radiology or pathology, where it may be less patient facing. So I think always just come back to what's important to me, what will give me the biggest satisfaction, because that's the way to be a good doctor in my eyes, is be satisfied with what you're doing.
Yeah, and that reminds me of the statement that medicine is only part of your life, it's not your entire life. So it's really good to explore those different interests. We're on to our last question, which I'm always interested in hearing what the response is going to be. What is the best piece of advice you have been given that has shaped you as a clinician?
Brilliant question. I think probably the best advice I've ever been given is to if there's something that seems challenging, is to try it and see where you get to, and beg for forgiveness if you couldn't do it. So I think if there's an opportunity that you really want that comes up, and you've got a bit of imposter syndrome and you're not sure if you're going to be able to do it, we're all better than we think we are. I think we all. I'm 5 years into consultant. I still have imposter syndrome. I still have it every single day. I think living with imposter syndrome is you just have to live with it, accept that we all feel that, but never underestimate your potential, and never let anybody else underestimate your potential. Try it. If it doesn't work, you can always beg for forgiveness, but actually don't put ceilings on your own potential. I think lots of people, so I was always told, just don't see the barriers, see the opportunities. And I think for me, it's that's been the most valuable thing, is actually, what can we do differently, not how do we do the same thing the same. How can you be more like a tour guide than a travel agent? So a travel agent sits there and sends you on a journey. A tour guide takes you with them and shows you what the world can look like. And so the biggest bit of advice I would say that I've had and I would give to others is, try and be a tour guide, try not to be a travel agent.
I've never heard that piece of advice before, so I'm definitely going to keep it with me. That's really, really insightful. With that being said, that is the end of the podcast. So thank you so much for speaking to us today. I'm sure the listeners took at least something away from what you said. And as I said before, I will link your podcast and also your email address if they want to get more involved in shadowing at Valindra or anything like that. But thank you so much, Dr. Frazer.
Delighted. Thank you so much. Have a lovely day.